Good morning. For today's lecture, we will have a brief discussion on the management of open and deep bite. As for the learning outcome, at the end of the lecture, the student should be able to identify the etiology of open bite and deep bite and also formulate the treatment plan for open bite and deep bite. So what is an open bite? As for the definition, it is the failure of a tooth or teeth to meet their antagonist in the opposite arch. It is also known as apertognathia. In simpler terms, it is a condition of malocclusion wherein there is no overlap between the maxillary and mandibular dentition. This is a malocclusion occurring in a vertical plane, and the area of occurrence could be either anterior or posterior. Now, coming to the etiology, this can have a multifactorial etiology, and it could be due to one or more reasons such as prolonged thumb sucking habit, tongue thrusting habit, nasopharyngeal obstruction, and any associated mouth breathing, and also seen in patients having increased tongue size and abnormal growth pattern of the maxilla and mandible. Some of the features of a skeletal open bite: you can see the patient has an increase in the lower facial height, decreased upper anterior facial height, increased anterior and decreased posterior facial height. There will be a steep mandibular plane angle noticeable in these individuals. Also, the mandible, the body of the mandible and the ramus can be small. Presence of a shorter upper lip with increased incisor exposure is a common occurrence in these patients. Also, the patients exhibit long and narrow face, steep anterior cranial base. Clockwise rotation of the mandible is seen with some extrusion of molars. Now, coming to the dental features, you can easily notice proclined upper anterior teeth. Upper and lower anteriors will definitely fail to overlap each other, and also the presence of a narrow maxillary arch due to the lowered tongue posture. How do you diagnose these patients? There is clinically, you can see the presence of an overbite in the patients showing an overbite of more than 1 millimeters, which is classified as a simple overbite, which occurs between the incisors. There can also be an overbite of less than 1 millimeters, which is known as a pseudo open bite, and the severity can go beyond 1 millimeters, and that is known as a complex overbite, wherein the overbite extends from one premolar area to the other premolar area, or in deciduous dentition it can extend from one quadrant to the other. And also there is something known as compound or infantile open bite, which includes an overbite, an open bite seen in the anterior and the posterior region, and also it can be secondary to any treatment, that is iatrogenic open bite, which is secondary to any other correction undertaken. The diagnosis can be further confirmed by a cephalometric analysis, wherein you can determine if the patient has a vertical growth pattern or a horizontal growth pattern. How do we manage open bite? The management can be classified as orthodontic correction, surgical correction, and a combination approach. So the orthodontic correction will include breaking any habits through the use of tongue trip or a vestibular screen. You can also use myofunctional appliances such as activator, bionator, Frankwell 4, twin block appliance, or a Jasper jumper to treat these malocclusions if you catch them early. Also, you can use fixed appliances through multi-loop edgewise arch wire technique, tip edge technique. You can place headgears to intrude and extrude simultaneously. You can also use elastics, you can use implants, which is quite a common approach of late, and also the use of removable appliances with posterior bite blocks, or you can place bite turbos in these patients to in conjunction with fixed appliance therapy. So anterior open bite can usually be treated using a palatal acrylic plate with a horseshoe-shaped wire crib and labial bow. Here the crib is placed 2 to 3 millimeters lingual to the upper incisors or at the gingival 1/3. This is for the correction of anterior open bite. When it comes to the posterior open bite, the crib is placed 2 to 3 millimeters away from the teeth, and the fixed tongue cribs are also used in conjunction with other correction devices. So here there is a brief discussion on the construction of vestibular screen. This is an acrylic shield extending vertically from the upper labial fold to the lower labial fold and horizontally from the distal margin of the last erupted molar on one side to another. This helps in the achievement of a proper seal, thereby creating a somatic swallow pattern, that is a normal swallow pattern, and also it should be worn at night and 2 to 3 hours during daytime. Lip exercises are also performed and taught to the patient along with the use of this appliance. There can be certain modifications for these. You can place some breathing holes to ease breathing for the patient if they have mouth breathing habit, and also you can place a tongue crib if the patient has a tongue thrust habit. Elastics are also commonly used. So this was in as early as 1991 by Viazis, who used a combination of upper stainless steel wire and lower rectangular nitty wire and used vertical elastics to correct both anterior and posterior open bites. However, it was in 1994 wherein two vertical elastics, one on either side of the midline, extending from a Kobayashi hook on the lower centrals to the upper centrals, and then to the lateral lower laterals was used to correct anterior bite. This has been widely accepted and widely used method to treat anterior open bite. Now coming to the implants, use of implants has been drastically increasing in the field of orthodontics. So it was Beth Prosterman in 1995 who described the use of implants for the correction of open bite. The authors concluded that since osseointegrated titanium implants show remarkable resilience to pressure, they can prevent extrusion of mandibular posterior teeth, thereby preventing increase in the anterior facial height. So this was one of the advantages achieved through the use of implants, and hence it has been recommended as a standard treatment approach. They also advocated the use of implants in conjunction with fixed appliances to correct anterior open bite. This again is the technique employed currently by various orthodontists and various schools of thought to treat anterior open bite. However, there is an extreme and invasive approach through the surgical correction. Here you can perform an anterior maxillary and mandibular subapical osteotomy. There is also a modification to this subapical osteotomy by Coles. There is also a sagittal split ramus osteotomy, Leafort 1 osteotomy, and also you can provide the patient with other adjunctive surgical procedures such as a deep lingual frenectomy, genioplasty. However, all these should have a thorough examination of the TMJ and any implications arising from that. So it has to be considered during the treatment planning and surgical correction and post-surgical treatment you will be providing to the patient. So with that, we've had a brief explanation on the correction and management of open bite. Now let's go to a deep bite. So it was Graeber who defined deep bite as a condition of excessive overbite where the vertical measurement between the maxillary and the mandibular incisal margins is excessive when the mandible is brought into habitual or centric occlusion. So this is a condition where there is excessive vertical overlapping of the mandibular anteriors by maxillary anteriors. So this is what is known as a deep bite. So one of the frequent malocclusion that can occur with other associated malocclusions is a deep bite. So deep bite is quite a common occurrence, and it is also one of the most damaging malocclusions as it can cause traumatic occlusion and mobility of teeth and several other complications associated with the deep bite. So here the features, the patient exhibits a horizontal growth pattern. The anterior facial height is greatly reduced freeway space, and on a cephalometric analysis, you will find that the mandibular plane, Frankfurt horizontal plane, SL plane are all parallel to each other, and they don't have a normal angulation as seen in a normal individual. So when it comes to a dental deep bite, it is characterized by the absence of any skeletal complicating features that are seen in skeletal deep bites. It can be either due to supraeruption of the incisors or infraocclusion of the molars. So it can be because of one or more one of these reasons. So deep bite due to over-eruption of anteriors is usually seen in class 2 malocclusion. Here there is presence of increased overjet which allows the lower incisors to over-erupt until they meet the palatal mucosa. So this is what causes deep bite in these class 2 malocclusion individuals. Also there is excessive curve of speed, and also the interocclusal clearance is however found to be normal. Um, Deep bite occurring due to infraocclusion of molars. Here there is presence of lateral tongue posture or lateral tongue thrust, which prevents the molars from erupting to the normal occlusal level. Also can occur due to the loss of premature loss of the teeth, and also it can occur in partially erupted molars and the presence of a large interocclusal clearance, wherein it allows the uh, anterior teeth to erupt beyond their normal position. So how do you diagnose a deep bite? Clinical examination, you can have study models and also through a cephalogram. So a proper diagnosis should be done to differentiate between the skeletal and dental deep bite. A lateral cephalogram helps in diagnosing a specific skeletal deep bite case. And also you can see there is reduced mandibular angle and also reduced lower anterior facial height. So, what are some of the factors to be considered in the treatment of deep bite? Deep bite can be corrected by intrusion of the anterior teeth or by extrusion of the posterior teeth. However, depending on the individual malocclusion and any other associated malocclusions, you have to take a decision based on case by case approach. So there are some of the factors which will decide if you will intrude the anteriors or extrude posteriors. This depends on the lip relationship, consideration of the vertical facial relationship, and also consideration of the uh, current interocclusal space. So when it comes to treating deep bite, you can use removable appliances or fixed appliances. So removable appliances are anterior bite planes, which are the most commonly used appliance. It is nothing but a modified Holly appliance with a flat ledge of acrylic behind the upper anteriors. When the patient bites, the mandibular incisors will contact the bite plane and disocclude, thereby allowing the posterior teeth to erupt freely. So that is the principle employed in an anterior bite plane. Also, if you notice this in a developing individual, you can use a myofunctional appliance such as an activator, bionator, twin block, or a Frankel appliance. We have discussed more on this in myofunctional appliances, so you can always refer back. Also, these individuals can be treated with fixed appliance therapy. Here, the fixed appliances are used to intrude the anteriors. You can use several methods. One is the use of anchorage bends. It is given mesial to the molar tubes so that the anterior part of the wire is gingival to the bracket. It is seen on the image. So you pull the wire down and then engage so that it has an intrusive force on the anteriors. Also, when this is used in both BEG and straight wire appliance therapies. So as I told you earlier, we just place a V-bend and the wire is pulled and engaged into the brackets, thereby exerting a intrusive force on the anteriors. Also, arch wires with a reverse curve of P has been used to treat deep bite. Here, the resilient wires, which are curved in the opposite direction to the normal curve of P, can be used to intrude anteriors. This again brings about intrusion of anteriors and extrusion of posterior teeth. The other method is to use utility arches. Here, the wires are bent in such a way that they bypass the buccal segment, as you can see on the image, and are engaged directly into the incisors. When they are activated by giving a V-bend in the buccal segment, this will again produce an intrusive force on the anterior teeth. So this can also be used in conjunction with other approaches so that you can effect an intrusive intrusion of the anterior teeth and correct any existing deep bite. So these are some of the ways of treating both open bite and deep bite. So with that, we've come to the last slide of today's lecture. So I've kept the lecture very brief and short so that the concepts and the principles spoken are clear and easy to understand. So today we've discussed the etiology of open bite and deep bite. How do you diagnose open bite and deep bite, and also what are the different treatment approaches you can employ in treating deep bite and an open bite case. So with that, we shall wind up today's lecture. Thank you so much for listening.